This conference will now be recorded.
Good morning, everyone. Today's topic is antiphospholipid syndrome. It is one of the important questions for you, might be one of the long questions for you in your final exam, and sometimes it is asked in your Viva as well. Um, so what is antiphospholipid syndrome? It is a separate topic. Actually, you must learn it. You must know what is this entity, and you must know what are its basic principles and how to what are its basic treatment plans. Antiphospholipid syndrome is an autoimmune disorder which manifests clinically as a recurrent arterial or venous thrombosis and or fetal loss. Characteristic lab abnormality exists as antibodies directed against membrane anionic phospholipids or their associated plasma proteins. As you might have known, the antibodies develop against the plasma membranes of our body. That is the basic concept of this development of antibodies, just like antiglomerular basement membrane syndrome, Wood-Castor syndrome. There is development of antibodies against the plasma membranes. So that is the basic concept, and you will come across these type of diseases much more when you go to the higher level. It is also known as Hughes syndrome, named after Grant Hughes, also known as lupus anticoagulant syndrome. It is mostly associated with systemic lupus erythematosus. It is responsible for frequent miscarriages in young females. Whenever the question is asked in Viva or whatever the situation is, it is one of the important causes of frequent abortions in young females, particularly in the second trimester. And you must know that it is one of the important cause of the frequent miscarriages in young females. There are three basic types of antiphospholipid syndrome, which is primary, secondary, and catastrophic. Primary antiphospholipid syndrome. Whenever I use APS, you must know that it is an antiphospholipid syndrome, and it occurs in the absence of any other related disease. It just happens because of the development of autoantibodies against the plasma membranes. It is a primary antiphospholipid syndrome. Secondary antiphospholipid syndrome occurs as a context of other autoimmune diseases such as systemic lupus erythematosus. It coexists with other autoimmune diseases. And catastrophic antiphospholipid syndrome. In rare cases, antiphospholipid syndrome leads to rapid organ failure due to generalized thrombosis. You must understand that antiphospholipid syndrome is basically a thrombotic disease. The formation of thrombus, you might know what is the meaning of thrombus. Maybe the aggregation of platelets and the other factors or other things lead to the formation of thrombus, and it leads to the blockage of blood wherever the thrombus is formed. And what are all the features that we discuss of the antiphospholipid syndrome are because of the thrombus formation. You might have known many things. Because of the thrombus formation, there's there is infarction happens everywhere. Whenever the thrombus is formed in the coronary arteries, it leads to myocardial infarction. Whenever the thrombus is formed, in the peripheral arteries, the diseases like Raynaud's and something like that. It's one of the things of a thrombosis. It's one of the all the features developed because of the thrombus formation. Epidemiology. APL means antiphospholipid antibodies. Here APL, wherever it is mentioned, you have to know that it's an antiphospholipid. In healthy people, frequency of antiphospholipid antibodies is 1 to 5%. Prevalence increases with age in elderly with chronic. The woman has more antiphospholipid antibodies. Females all present with arthritis, livedo, reticularis, migraine, males, myocardial infarction, epilepsy. Whenever the thrombus occurs in cerebral arteries, it may lead to stroke and epilepsy as well. Although antiphospholipid antibodies are clinically linked to antiphospholipid syndrome, whether they are involved in pathogenesis is unclear. What are the infections that might lead to antiphospholipid antibody syndrome? Some are here: syphilis, hepatitis, HIV, malaria, and like that. And the drugs which lead to the formation of thrombus, which are procainamide, quinidine, propranolol, hydralazine, phenytoin. You know, there are some anti-epileptic drugs. You must remember quinine is an anti-malarial. Genetic predisposition, it is somewhat important for your, you know, the later coming the objective type assessment questions. HLA, DRW53 and DR7, which are associated with antiphospholipids. You know, the basic thing, as I already mentioned, is the development of antiphospholipid antibodies. That is the thing. The patients develop antiphospholipid antibodies, and it leads to the thrombus formation, and it leads to the clinical manifestations of the disease. The three antiphospholipid antibodies are anti-cardiolipin antibodies, lupus anticoagulant, and anti-beta-2 glycoprotein 1 antibodies. These three are very important. These, if a question is given that antiphospholipid antibodies syndrome, you can start with these three: development of antiphospholipid antibodies. And if you mention these three names, that anti-cardiolipin antibodies, lupus anticoagulant, and anti-beta-2 glycoprotein 1 antibodies, I'm sure you get a half of the marks. Everything is dependent on these three antibodies. So you must know, it is very important for your future examinations as well. This is very important topic for, you know, your upcoming NEET or whatever, even in the final examinations, Viva is one important question. These three antibodies, you must know the names of these three antibodies: anti-cardiolipin antibody, lupus anticoagulant, and anti-beta-2 glycoprotein 1 antibody. There may be beta-2 glycoprotein 1 dependent or independent ones, but it's very important that you remember these three. Serum assess, you can, you know, measure anti-cardiolipin antibodies and anti-beta-2 glycoprotein antibodies. As I can, you can assess the, you can quantify them. I mean, whether they are increased in our body, whether they are increased in our serum, through ELISA methods, as we check the other antibodies, antibodies formed against other things, as we are now checking for even for COVID. As simple as that, you just assess them, you just quantify them, whether they are increased, whether the number is increased or not. Plotting assays, as I said, it's a basically the clinical features are because of thrombosis, and you know that the effects of the antiphospholipid on the phospholipid dependent factors in this coagulation cascade, that is lupus anticoagulant test. You just remember the name lupus, and I will discuss it later. What is the basic pathophysiology of this antiphospholipid syndrome? The development of antiphospholipid, I already said, whenever the APL comes, it is antiphospholipid. Antibodies are heterogeneous and targets many things. Under physiological conditions, beta-2 glycoprotein acts as the elimination of apoptotic cells and as a natural anticoagulant. There are distinct clinical laboratory biochemical difference between these three, basically. So whenever there is a ACL means anti-cardiolipin there. So whenever there is increase in anti-cardiolipin antibodies, there is a risk of stroke because of arterial thrombosis. So when you get a doubt on whether it is antiphospholipid syndrome or not, and you quantified the anti-cardiolipin antibodies, and if they are increased, then you must know that this patient is an increased risk of stroke because of the development of arterial thrombosis. Whenever there is an increase in lupus anticoagulant, that is LI is mentioned there, then it is venous thrombosis. And whenever there is increase in TNF alpha, factors, and the increase in complements, then there is a chance of pregnancy loss. It is very important for your future examinations. You just remember these three: anticardiolipin increases arterial thrombosis, lupus anticoagulant, venous thrombosis, and TNF alpha is pregnancy loss. It's very important for your, the next NEET examinations usually. So basic pathophysiology, you try to remember the names. Basically, the order at which they act and the mechanism might not be that useful to you, might not be that needed for you as well. But just remember, first initiate it with the activation or or defective apoptosis of platelets. You know what is apoptosis, right? It is a programmed cell death. Apoptosis happens every day in our body, and apoptotic cells, I mean, because of the apoptosis, the old cells get lost and the new cells get formed. Usually that is needed in our body, the process. Sometimes when it is apoptosis is controlled by various factors, and if there is any discrepancy in their action or whatever, if the apoptosis, the mechanism of apoptosis is deranged, then there is a problem. The problem can be anywhere, or the good drainage of the old cells, or in the mechanism of formation of new cells, or whatever. if it is deranged, the cell death, if it is increased, now there is a problem. If it is decreased, there is a problem. So it has to be you know arranged in a neat manner. So whether there is an activation, that is excess apoptosis or defective apoptosis of platelets, endothelial cells, or trophoblasts, then phosphatidylserine or cardiolipin migrates to the outer cell surface, and there is a circulating beta 2 glycoprotein 1. These things might not be that useful, but try to just mention the names. It's a defective apoptosis. And if a question is given, just write the circulating beta 2 glycoprotein 1s, just bind to them, and there is an activation of complement and the release of cytokines. Just remember that. And now, how are they organized? When there is a defect in cellular apoptosis, the exposure of membrane phospholipids to binding of various plasma, as a it's a continuation of the previous slide. Just beta 2 glycoprotein 1 complex is activated because of the antibodies, and then it might lead to complement activation. Whenever there is complement activation, there can be a pregnancy loss. There is a chance of pregnancy loss. This is very important. Whenever there is a complement activation, I already mentioned, when there is increase in anticardiolipin antibodies, there is arterial thrombosis. When lupus anticoagulant, it's venous thrombosis. Or when it is complement activation, then it is a pregnancy loss. The other proposed mechanisms, apart from beta 2 glycoprotein 1 complex and complement activation, are these things: production of antibodies against prothrombin protein C. Don't get intimidated by seeing all of this. You need not remember all these things. You just have an idea of what is the basic pathophysiology it is. You just don't have to write everything here. Just to give you an idea, and just give it. What is important to you is the antibody names and the basically how they act, and what are the clinical features, and what is the treatment. You don't get deep into these things. Just listen and have a glance what's happening there. Activation of platelets to enhance endothelial adherence, activation of vascular endothelium. So what might be the possible consequences of the thrombosis? Basically, as I said, it's basically a disease of thrombosis. Thrombosis happens because of the complement activation of whatever. So these are all the possible consequences of antiphospholipid syndrome. These things might happen when it comes to cardiovascular system. As I said, whenever there is thrombosis in coronary arteries, it might lead to cerebrovascular accident. That is embolic stroke. Whenever the thrombus is formed in the coronary arteries and that dislodges into the brain, so cerebrovascular accident can happen. Signs: thrombosis, cardiovalvulopathy, or myocardial infarction. You just remember the thrombosis, and you can write all these names. Dermatologic, livedo, reticularis, purpura, infarcts can happen because of the thrombosis. And it is hematologic: thrombocytopenia, hemolytic anemia, arterial or venous thromboembolic disease, musculoskeletal, vascular necrosis of the bone, and other infarctions or hemorrhage. Neurologic, stroke, transient ischemic attacks, whatever, what is important, very, very important that you must mention is obstetric ones. The pregnancy loss is one of the diagnostic criteria for the antiphospholipid antibody syndrome. So you have to write the spontaneous abortions, preterm deliveries, preeclampsia, and eclampsia. It is very important. Whatever it is, spontaneous abortions in a pregnant female, you must think of antiphospholipid antibodies. Pulmonary, pulmonary embolism. So as I said earlier, cerebrovascular accident and myocardial infarction in young patients, then you have to suspect antiphospholipid syndrome. Secondary to valvular vegetations, embolizations, or in situ thrombosis, or if there is any recurrent pulmonary embolism, whatever it is, you just have to go to the basic point of thrombotic phenomena, and you can apply it. Whether it is brain, it is CVA; in lungs, it is embolism; in heart, it is myocardial infarction; and in legs, it is arterial thrombus. Whatever, it just comes to thrombotic phenomena. What is the clinical criteria for APS? It is very important. You must have to by heart it. You have to remember it basically. Venous thromboembolic diseases, arterial thromboembolic disease, and small vessel thrombosis. This is vascular thrombosis, as I already said: venous, arterial, and small vessel. Pregnancy morbidity. if you suspect any of these things in a pregnant female, you must suspect antiphospholipid antibody syndrome. One or more unexplained deaths of a morphologically normal fetus at or beyond 10th week of gestation. This 10th week of gestation is very important for your future examinations as well as in your viva. Usually beyond 10th week is already know first trimester is up to 12th week. So you have to remember it is just beyond, it's not in the first trimester deaths, it's mostly in the second trimester deaths happen. 3 or more unexplained spontaneous abortions at or prior to 10th week of gestation. Then you have to remember that there are 3 or more unexplained spontaneous abortions of a normal 10th week of gestation, and 1 or more premature births at or before the 34th week of gestation due to eclampsia or placental insufficiency. You have to remember this clinical criteria there. And what are the lab investigations that you order for antiphospholipid syndrome? There is lupus anticoagulant, anti-cardiolipin antibody, that is IgG or IgM antibody, and anti-beta-2 glycoprotein IgG or IgM antibody. As I said, you have to remember these 3 names: lupus anticoagulant, anti-cardiolipin, and anti-beta-2 glycoprotein. And this is not revised criteria and all that. That's not that important to you. And thrombosis. Here, deep vein thrombosis and pulmonary, as I already said, what are all the options are very, very important. Hematology, and I was already explained them. So, what happens when there is a venous thrombosis? So, there can be deep vein thrombosis of the legs, as you can see. There can be ascites, that is the Buchiari syndrome. Tachypnea can occur because of the pulmonary embolism. Abnormal fundus examination, there can be retinal vein thrombosis. It's all because of thrombus phenomena. More than 50% have asymptomatic pulmonary embolism. And unusual anatomic locations, cerebral veins, superior sagittal sinus, and whatever. So Buchiari syndrome is an entity that you must know, and you must refer that it refers to the hepatic vein thrombosis. Whenever you suspect Buchiari syndrome as well, you should know that there can be an undergoing antiphospholipid antibody thing that's happening there. So these are the consequences of venous thrombosis. This is this is how the retinal vein thrombosis can look like in a fundus examination. And what are the consequences of arterial thrombosis? It is usually a less common phenomena than venous thrombosis. As I already said, anti-cardiolipin antibodies, whenever they are present, it might lead to an arterial thrombosis. Present with TIA means transient ischemic attack. You must have known what is a transient ischemic attack. Transient ischemic attack is one having a symptoms of stroke but get results within 24 hours. There can be speech abnormality, or there can be any fall, or any loss of consciousness attacks, or something. Sometimes even weakness can occur. But it all recurs before 24 hours. And when we do an imaging, that is when we do MRI, that we found nothing. We just have no infarct, no hemorrhage, and that is the meaning of transient ischemic attack. Or stroke or myocardial infarction can occur. As you all already know what you mean by gangrene, it's loss of blood supply. Whenever there is a thrombus occluding the blood vessels, then there can be a gangrene of distal extremities. Brachial or subclavian arteries, unusual sites, or whatever, heart murmurs and all. Lippmann-Sachs endocarditis, you might have known that it in systemic lupus erythematosus. You can remember that for for your future examinations. But important thing there is there can be transient ischemic attack or stroke, recurrent strokes, or if there is recurrent MI in young patients, you must suspect antiphospholipid antibody syndrome. What are the cardiac disorders? Thrombotic or embolic premature atherosclerosis or occlusion, young age with no risk factors for cardiovascular disease, valvular thickening. These are all things that can happen in cardiac disorder. What are important things that you have to remember is myocardial infarction is one thing you must write, or something atherosclerotic phenomena can be ongoing, and valvular thickening, aortic artery. These are important things that you must mention definitely. Cutaneous livedo reticularis. I will show the picture. And superficial thrombophlebitis, leg ulcers, painful. These are all the manifestations. These are all the thrombotic phenomena that can happen. Cutaneous, cardiovascular, neurologic, whatever. You must, as I said, you must remember the basic phenomena of thrombotic phenomena happening because of the antiphospholipid antibodies. You can have, for a theory sake, you can mention. It's very important for you in your NEET examinations usually, which is Sneddon syndrome. It is livedo reticularis, stroke, and antiphospholipid antibody may or may not be associated with antiphospholipid syndromes. Just for theory sake, it is not a clinical entity. This is what is livedo reticularis. It's because of the cutaneous wells are blocked, so you can see, that thing that livedo reticularis. It's like a net that's happening. As I already said, neurologic disorders, strokes are important thing. Chorea migraine can also occur. Guillain-Barré syndrome, optic neuritis. Multiple sclerosis, it mimics multiple sclerosis usually because of the cognitive dysfunction. But important thing that you have to write is thrombotic or embolic phenomena, and of course, migraine is also important thing. Obstetric, of all this, what is important is obstetric, recurrent miscarriages, fetal demise, eclampsia, and all those things. As I already mentioned, pulmonary, abdominal, endocrine things. Buchiari syndrome is of prime importance that you should mention whenever the question is given. Retinal, A is renal. So what are all the entities? You must remember it affects all the organs. Antiphospholipid syndrome. You have to remember the basic thrombotic phenomena and know and write the diseases particular, pertaining to that particular phenomena. That is renal. Thrombosis renal in renal vasculature, thrombotic microangiopathy, proteinuria with hypercomplementemia, hypertension. Just remember the names. That's it. What is the third entity? Catastrophic antiphospholipid syndrome. It is a syndrome of multi-system involvement. Usually, very less number of patients are involved. There are multiple small vessel occlusions. There is multi-organ failure, which is acute onset, and 3 different organ systems involved in a week. Acute microangiopathy is characteristic. It usually leads to higher mortality, and also the symptoms tend to occur very frequently and very fast. The patient gets deteriorated very fast, and you have to act accordingly by giving steroids or whatever. So usually in these patients, the mortality is very high. As I already said, how to diagnose the antiphospholipid antibodies. It is mostly lab, it's lab diagnosis. So IgG and IgM anti-cardiolipin and anti-beta to glycoprotein antibodies by ELISA. And locus anticoagulant testing, and repeat the assay up to 12 weeks to confirm the diagnosis. Consider the third test if the initial trial is for high and a strong clinical suspicion after second test comes negative. And ESR, hemoglobin, and TLC are usually normal. What are the important differential diagnosis of antiphospholipids? You have to remember these are all in the left: inherited and acquired thrombophilias, protein C and proteinase deficiency, factor V lead. These are all the causes of usually the stroke in young. You can also have that perspective that protein C and proteinase deficiency, factor V lead deficiency, homocystinemia, and all these things are one of the causes of stroke in young. So it can become the differential diagnosis of antiphospholipid antibody syndrome. And of course, the other things, acquired things, acquired thrombotic pregnancy and postpartum, whatever, after major surgery and all those things. Differentials of CAPS, catastrophic antiphospholipid syndrome. HELP syndrome, you might have known, you must have read in obstetrics, that is, elevated liver enzymes, low platelet count, hemolysis going, and all those things. It is one of the differential diagnosis of APS, sepsis, or DAC, disseminated intravascular coagulation. And coming to treatment, remember that usually for secondary thrombosis prevention, lifelong warfarin is to be given. Remember that lifelong warfarin is given for antiphospholipid antibody syndrome. If you have to answer in one line, what is the basic treatment for antiphospholipid syndrome? It is lifelong warfarin for normal patients. Primary thrombosis prevention in individuals who are persistently APL positive, lacks an evidence-based, all that not required. And for the prevention of fetal loss in patients who have a prior history of fetal loss include a low dose aspirin and low molecular weight heparin. So in normal patients, we have to give lifelong warfarin. In a pregnant patients, we have to give low molecular weight heparin and low dose aspirin. So according to the Sapporo criteria of antiphospholipid, Sapporo antiphospholipid criteria. So what is important is you just remember the names: long-term warfarin for normal patients. For pregnant patients, you have to give aspirin and heparin. Heparin is the first thing you remember for giving for the treatment of pregnant patients. And those three names, if you write, basically this question is given as a theory question for you. Write the three antibody names: anti-cardiolipin antibodies, and lupus anticoagulant and anti-beta2. Right? What are all the manifestations? As I've said, 12 organs are involved: renal, obstetric is involved, neurologic, and all those basic things. And the treatment, if you write that lifelong warfarin and low dose aspirin and heparin, I'm sure that you have completed the bulk of the question as far as your theory exam is concerned. That is what are all the things that I've mentioned. Apart from those, you can write in addition, but this is the basic structural format of how to approach this question if it's going to be in theory. And for the practical or viva sake, you just have to remember for arterial thrombosis, venous thrombosis, and as I've said, complement activation. And what are all the, as I said, anticardiolipin for arterial thrombosis, lupus anticoagulant for venous thrombosis, and those are all for the future examinations. In pregnancy, use heparin. Heparin also prevents antiphospholipid induced to complement activation. As I already said, the pregnancy loss is because of the complement activation. So heparin prevents the complement activation as well. The previously prednisolone was used, no benefit, as per intravenous immunoglobulins and hydroxychloroquine may be considered in patients who fail treatment with heparin. If heparin doesn't work, then we can give intravenous immunoglobulins and hydroxychloroquine. If you are getting confused, forget all these things. Heparin for pregnant females along with low dose aspirin, warfarin for normal patients. You just can remember those things. That would be enough. As I said again, whenever the warfarin is given, you have to check the INR of the patient. It has to be around the 2 to 3. The normal INR is around 1, but when you're giving warfarin, you have to maintain at the range of 2 to 3. Arterial thrombosis, as I said, warfarin for everything. In catastrophic APS, where we have to act fast, then we have to do anticoagulation, that is heparin or warfarin along with the corticosteroids. Steroids are indicated in catastrophic APS. And another thing, this is how to give and all that is prophylactic heparin and all that. It's not be that important, but try to remember that heparin has to be given and how it is. And if there is a thrombocytopenia in these patients, you have to, if there is a platelet count is more than 50,000, no treatment is necessary. If the platelet count is less than 50,000, then prednisolone, that is steroid, has to be given. What are the aspirin dose? 80 mg per day has to be given. Enoxaparin, which is a heparin. So enoxaparin means it's one of the variant of heparin. So it has to be given 0.5 mg per kg subcutaneous once daily, prophylactic. But usually lifelong anticoagulation, that is lifelong warfarin, has to be given. What are the alternatives to warfarin if it doesn't work? Aspirin and clopidogrel can be given. Corticosteroids can be given up for short term. Corticosteroids should never be used as a lifelong therapy. And other things, hydroxychloroquine, statins can be given, but warfarin usually works better. And these are the other things that can be given: hydroxychloroquine, statins, rituximab, clopidogrel. These can be considered when warfarin or heparin fails, or whenever there is an allergy or something. You can just remember the other treatment modalities. You can write the heading and you can mention these names. These are all the doses which are not that important. Remember the warfarin dose. It's 5 to 15 mg per day. It's a APTT. You have to, for warfarin, you have to do PTINR. These are all the new drugs which will be used for future examination: rituximab and eculizumab, and autologous hematopoietic stem cell transplantation. Remember this. Remember the name rituximab. You got to hear this name many times in your future, and it can be even given for APLA. Thank you. As I already said, just remember the basic things first and go through this question once. It's an important question, no doubt. Given it will be given in theory. It can be given in theory examinations. Thank you. Mhm.